So this is a 55 years old female known case of diabetes recently diagnosed, and she presented with chest discomfort since morning within 4 hours of her chest discomfort, and she has autonomic symptoms, and they went to some local hospital and they took a ECG, and the ECG was uh, there was a hyperacute T wave in anterior lead and ST coving. And then this patient presented to us, and on arrival in the emergency, the ECG showing frank ST elevation V1 to V6 with the reciprocal changes in the inferior lead, and on echo there is RWMA, severe LVD systolic dysfunction, as you can see. And this after counseling, this patient was taken for the emergency PTCM, and this is the angio view. We can see there is a 100% thrombotic occlusions right from the ostium of the LAD. This is the RA view, and you can see the same thing right from the ostium of the LAD here near the arrow. There's a thrombotic occlusion in the LAD. The other LCX and RCA was normal. You can see the RCA is normal, dominant. And then after counseling and the risk and the prognosis, we took up this patient for the sort of primary angioplasty, and this is a right radial root, and we do a maximum patient with radial root because we have to avoid the complications which can occur in the femoral root. So patient was very obese, and this is the right radial root with XB 3.0 6 French, and this engaged. So I took a workhorse wire which was run through, and easily I crossed the lesion, but as always the flow is not there. Even this is the cranial root, and you can see the wire. So this wire seems to be in the LAD, but there is no flow, and I was sort of sure that wire is in the LAD because you can see the shape. This is cranial view, and then again with gentle movement I progress the wire, and this is the progression of wire. And then given Tarifib, Nicoron, everything we have given, but the flow hasn't come. So this is the normal scenario in the ACS. You will not get flow still. So doing balloon daughtering in this case is a risky task because this thrombus may come to the left main and can block the LCX also. But then there was no any other option. So with gently we decided to do balloon daughtering. So many times nothing will happen with some sort of organized thrombus. So this is the balloon daughtering. Balloon daughtering is a simple to and fro movement of the balloon so that thrombus will get clear and will get flow. This was a balloon daughtering we have done in the hope of getting flow in the LAD. So as expected, flow has come, and you can see the probably plaque in the proximal LAD. So the thing is, such a ostial LAD lesion, if we predilate before stent, then there's a chances of this thrombus to migrate to the LM, and can cause the LCX to get blocked and then other consequences. So generally I avoid to do a predilatation. In rare cases I do the predilatation if it is not the ostial near the ostium. So if I can see the length of the stent and everything, then generally I don't do the predilatation, and if it is not even calcified, it's only pure thrombus. So in this cranial view we can see the same thing. You can see the TIMI1 flow in the LAD, and we're very sure that wire was in the LAD. So after doing balloon daughtering, we took a stent, and it was 3.5 into 28 as there was lesion in the proximal LAD, and right from the ostium it was closed. So I decided to put a stent right from the ostium of the LAD. And you see this is the placement, and I was checking the position of the stent, and meanwhile patient got the VT because there was no flow at all. And then we have given shock, and then again and then VT reverted, and then inflated the stent as early as possible. This was the inflation. Nominal was 8. We inflated up to 12. And this is a scene after the stent inflation, and you can see the still balloon is there. So I wanted to see whether it has opened up or whether there is any no flow, reflow, slow flow. But there was nothing, and you can see sort of thrombus just down the balloon. So we given tarifiban and nicoran, and then you can see that just below the stent there is some step down. So you can see this if your distal segment of the artery is less than the diameter of stent, it was probably 3 or 2.75 in the mid, but in the proximal, as we were putting the stent right from the ostium, and it was 3.5. So we had to take a long stent because there was a thrombus. So we had taken the 28. It was 3.5 28, and this is the final scene. You can see how wonderfully this LAD has opened up, and it was almost long LAD, type 4 LAD. And then this is a TME3 flow, and then that sort of haziness was disappeared. It was due to step down, step up. So this was the primary angioplasty to LAD. In this caudal view, we can see the how large and long the LAD is almost wrap around. This was the RAO caudal view, and you can see LAD has opened up, and there was no pinching of diagonal or something like.